Welcome to the official podcast for the Australian Podiatry Association. This is where we talk about a broad range of issues affecting podiatrists and their patients. My name's Nello Marino. I'm the CEO of the Australian Podiatry Association and delighted to be your host for today's episode. Osteoarthritis of the knee is a commonly diagnosed condition, and today we're discussing the role of the podiatrist in assessing and treating osteoarthritis, including when to refer for further treatments. We're joined by Narelle Window. Welcome, Narelle. It's great to see you again.
Hi, Nelly. Thanks very much for having me. It's great to be here.
Yeah, thanks for that. Narelle, just as a bit of a background, is a researcher and podiatrist in private practice in Hobart, who's combined clinical practice, and research since 2002, and has been a podiatrist for over 25 years. Hard to believe, Narelle. With a graduate diploma in human movement science, a Masters of Sports Medicine, and a PhD completed in 2019 at La Trobe University, Narelle is also an honorary research fellow in the School of Physiotherapy at the University of Queensland. Much of Narelle's research has focused on foot orthoses and their effect on foot and patellofemoral osteoarthritis. Narelle, the patellofemoral joint, or the PF joint, can be commonly affected by osteoarthritis, yet until only a few years ago, very little was known regarding non-surgical management or how effectively podiatrists could treat the condition. So tell us, as a real starting point, what is the difference between PF pain and PF osteoarthritis? Are they the same thing?
We think they may be different ends of the spectrum. Basically, patellofemoral pain in younger people is pretty similar to patellofemoral pain experienced in osteoarthritis. And we think the younger population who've had abnormal joint loads, which is usually the large driving factor in any kind of osteoarthritis in the lower limb. But what we think happens in the early stages of osteoarthritis in any compartment of the knee is that abnormal forces start to create some cartilage stresses and some underlying bone stress. And in younger people in the patellofemoral joint, they experience this as anterior knee pain. And if this isn't actually, this overload or abnormal load is not managed or changed over time, then we think this is what starts to drive joint changes as far as cartilage changes and subchondral bone changes. Then becomes visible as arthritis on some kind of imaging such as X-rays or MRI. So, we do think they are just different ends of the spectrum essentially.
Okay. So you touched on children in, you made special mention of particularly younger people, but what percentage of the population is affected by the condition, Narelle?
The younger population, there's been different studies, looking at sort of teenagers through to military recruits. When we say younger, I'm talking under 40. But generally, looking at the different studies, kind of an average would be around 20% of the population would experience some kind of patellofemoral joint pain over the course of their life. And then when we look at older populations, so over 40, if we look at people who have knee pain in this group, if we were to do MRIs, you would generally see about 70% of these people with knee pain would have some kind of patellofemoral joint change. So it's really, any kind of knee pain in an older population is very likely to have a patellofemoral component.
So we're talking about a relatively large portion of the population in general terms. If we're talking about 70% over 40 and 20% under 40, that's quite a significant number.
Yeah, it is. It's quite we know that, knee arthritis, if you look across the board, all kinds of knee arthritis, do average somewhere around the 20% mark of the population without pain. If you look at X-rays and or MRIs, a way of rating it, then you can say about 20% of the population.
So it's highly likely that podiatrists at some point will see this through their career, Narelle. What are some of the common symptoms that of PF pain and PF osteoarthritis?
The symptoms are pretty much anything that lowers the patellofemoral joint. So if you're sitting with your knees bent for prolonged periods, we've called this traditionally moviegoer's knee, where, halfway through the movie you go straighten your leg out, or if people recall what long plane flights were like. Then other activities, walking up and down stairs or hills are also notoriously uncomfortable. But what is important certainly in trying to tease out patellofemoral osteoarthritis from tibiofemoral osteoarthritis is that walking along the flat is not usually particularly painful for people with patellofemoral osteoarthritis. That's normally more the tibiofemoral joint, and it really is the slopes or the inclines that tend to get, younger or older people with patellofemoral joint loads. Yeah.
So you'll see. So effectively, a large portion of the population will see differences in how they feel after the sort of service or the sort of incline they're likely to walk on, as a general rule.
Yeah, often during the task. Sometimes it can be painful only during the task. It won't necessarily be painful after. Osteoarthritis can obviously be more painful afterwards, but it's normally an acute sort of discomfort felt, unless it's been sort of more of a chronic condition, and then you can get. Yeah. I think the thing that's also important to remember is in both conditions there can be pain provoked by bone stress, but there also can be pain provoked by soft tissue structures. So, particularly the fat pad that sits underneath the patella, that can be impinged and become quite inflamed, and that won't just be painful during the task. That can lead to a bit of a puffy knee after the event, and we think the inflammatory factors that can be released from this cranky fat pad can be part of the degenerative process as well.
So in some sense, Narelle, it points to some of the difficulties, I suppose, in diagnosing PF osteoarthritis. What are the sorts of assessments that a podiatrist might use, or in fact any practitioner for that matter, but we're obviously focused on podiatrists here, to help diagnose PF osteoarthritis?
Certainly the history is a big one, getting a thorough history from the patient, trying to tease out what are the tasks that cause the most pain. Are they the traditional, knee flexion type of tasks? And if that does seem to be the case, the location of symptoms described by the patient or on palpation aren't actually that helpful. Usually the pain is more around the patellofemoral joint, so like a donut shape around that anterior knee. But pain can often even be felt behind the knee with patellofemoral pain. It's quite odd, and palpating around anyone's knee, certainly with a degree of osteoarthritis, is painful everywhere. So palpation is not actually very helpful, and it's more where you can provoke pain on functional tests. So getting patients to do a single leg squat, standing on one leg if they can do safely. Certainly the older populations may find it challenging, but often they're quite hesitant to do any knee flexion because of how it will load the knee and cause pain. But it is tricky. If you have tibiofemoral osteoarthritis, that's still not a great task to do anyway. So there is quite a challenge, in trying to diagnose whether pain is coming primarily from the patellofemoral joint or the tibiofemoral joint in the older cohorts. And while X-rays are not, or MRIs aren't necessary in diagnosing osteoarthritis, it is quite helpful, I find, to know what joints show the greatest change, because whether that be on either imaging form, because it gives you some idea of the history of which compartment's been loaded the most abnormally for the longest, and can give some insight. But the medial tibiofemoral and patellofemoral joint are very commonly affected concurrently with osteoarthritis, and so sometimes you have to kind of manage both, really. And clinically, we are most likely to see that. 25% of people will have just the patellofemoral joint affected, but mostly it's combined. And so it is quite challenging. You're not going to be able to just treat one or the other. You have to treat them together.
Yeah, okay. So you've described well the complexity that goes with the whole diagnosis. And assessment. So what is the role of the podiatrist in assessing, diagnosing and providing treatment for PF pain and PF osteoarthritis, Narelle? I mean, yeah, how can they help?
Well, I think one of the things I really like about patellofemoral pain and osteoarthritis is we now have quite a few studies that are, really consistently supporting the role of foot-based interventions, be that improving footwear or the inclusion of any form of foot orthoses appears to be beneficial in any, part of the patellofemoral spectrum. It comes down to other factors for the patient as to what would be the best intervention. If it's a sporting person with patellofemoral pain, how you assess them is very different to how you assess a 60-year-old with, patellofemoral osteoarthritis. But essentially, getting an idea of what kind of loading their knee experiences, whether it be, how much they're running, what, surfaces they're running on, be it inclines, whether it's that they play bowls and there's lots of lunging involved, trying to get an idea of how we could manipulate, their training loads, if you like, be it whatever activities they undertake. But then when it comes to functional assessment of, their sort of intrinsic structure and function, the podiatrist and the foot and ankle region has a huge impact on the joints above it. So, even if the person, and this is something that I feel is starting to be borne out in the current literature, the person doesn't have to have a pronated foot. They don't have to have a highly mobile foot. Any of those things, we are finding, that if you provide an orthotic to a person with patellofemoral pain, there are probably other mechanisms at play we haven't yet been able to observe in a research setting, such as increased sensory input that's giving the brain better information regarding how to control the lower limb. But any kind of foot orthoses and increased feedback from footwear seems to improve pain and function in patellofemoral pain or osteoarthritis. So if you've got someone in front of you who hasn't got private health insurance, a cheap off-the-shelf orthotic is going to be helpful. If they can't or are resistant to orthotic, just get them into a stronger pair of shoes. All that's going to be helpful. Foot strengthening, we don't have any research looking at this just yet, but, some patients are really keen on more of a strengthening intervention, so foot and ankle strength work as well as hip strength, which is, I think, something podiatrists could easily include in our assessment, is a single leg squat test to look at knee valgus, which is, obviously knee adduction, to get an idea of hip strength. Another test I do commonly do, or do with all my patients, is the sit to stand task to get an idea of whether they can stand up on one leg from a chair, which is obviously not very, very nice to do if you have patellofemoral osteoarthritis, but that is kind of the point. These people have such inhibited quadriceps activity and gluteal activity that's a big factor that needs to be carefully addressed in their management as well. And I think we can, provide patients with some simple exercises, even the general podiatrist. Obviously, there are those more specialised in sports where we give a fair few more exercises. And if the person doesn't have lower back pain or too many other concerning conditions, say they've had a hip replacement, those patients you obviously want to refer to a physio, to your favourite physio colleague. But I think there's we should be a little braver and adding a few more simple, look, the Pilates instructor down the road will give half of these exercises out. I think we're completely within our professional scope to give a few of these basic exercises for quadriceps and glute strength as well. But, I think it's an area that we can confidently, as a profession, know we have good evidence behind, footwear and foot orthotic interventions, and very confidently provide them with a strong likelihood of some improvement.
You've touched on a few pieces that I was going to follow up with in this next question, Narelle, but you've touched on exercise, you've touched on footwear and orthotic devices that might assist. Specifically, where do you see the role of the podiatrist in this? I suppose, given we are focused very much on that in assessing, diagnosing and providing treatment for PF pain and PFOA.
We, in some instances, can be the only practitioner that needs to be involved. And this comes down, I think, a lot to patient preference as well. But, I think it's, for most part, a quick and easy fix for us if we get the patient into better footwear, some form of foot orthotic therapy. Our role can be the primary one, really. With patellofemoral osteoarthritis, it obviously becomes more complex, though. I think our role is then part of a multidisciplinary team, much more than it is for a younger cohort. In my older patients, we will often, the way I see our role as podiatrists is setting up the basic infrastructure of the lower limb posture and functional position with the orthotics and the footwear. And my favourite shoe, partly because it worked so beautifully in my PhD, is a New Balance 857 for this particular condition. And so once I've set up that patient, if they still have residual symptoms, then we do like to involve, obviously, the physiotherapist, particularly including a GLAD, like the GLAD program, which stands for Good Life with Arthritis Denmark, which a lot of physiotherapists provide, which is a general lower limb strengthening protocol for people with hip and knee arthritis. Make sure the patient's, hopefully attending or performing some more global lower limb strength work to help try and slow down the progression of the condition. But sometimes we do find great benefit with speaking with our sports physician colleagues to look at other, injectable therapies, whether it be some patients respond nicely to, a thin disc type injection. Some, if they have a bit more inflammatory features on MR, we might look at some cortisone injections. But our role, certainly in the more end stage part, becomes as part of a team. But in a 16-year-old with patellofemoral pain, we can be the bee's knees, we can be it. We don't necessarily need to include many others other than the physio.
Yep. So again, we're seeing that pattern of with age comes complexity, and as a consequence, the need for multidisciplinary interaction, involvement. Yeah. Okay. Again, you've probably touched on this, but what is your treatment plan for a patient with PF pain or PFOA? You've touched on it already, but is there anything else that you feel needs to be added to that?
So I think probably one of the biggest things that when we talk about orthotics and footwear, there's providing someone with the advice, to get the right shoes and the orthotic. But I think where we need to be very strong in educating the patient is it's about the duration of use of these interventions. So if you wear your amazing orthotics and shoes when you go out of the house, but you go out 3 times a week, that is not sufficient to change the joint loads. 4 days a week, you're walking around the house in your slippers or in your socks. That is going to be quite antagonistic to the joint. So we really need to try and explain to the patient we're trying to change as much as we can, you know, like if you think of the 10,000 steps a day we're all meant to do, that as many of those 10,000 steps can have an altered posture or loading pattern on all the joints of the lower limb, so that basically we are creating the environment for the body to heal itself. So if those little bone cells that have, you know, where you've had some bone stress, have been having a great time for those, you know, 5 hours you had your orthotics and footwear on while you're out doing the groceries, and they got a little bit of repair work done, and then you go home and take your shoes off and walk around in your slippers for the next 4 hours and make dinner, all their good work's undone. There's not going to be much gain. So, you know, I think most of us probably know we need to provide these interventions, but it's all in the dosage of them as well. Like we all think about dosage of exercises and the number of reps and so on, but our interventions, orthotics and shoes, are equally dose related. And I think that's a really strong point that, you know, we've got to quiz our patients about, you know, from the time they get up to the time they go to bed, what is on their feet. Every step is like a calorie in a diet. It all adds up. You can't cheat it. So
it's an interesting concept for many people to get their head around, isn't it? The idea that you know, that this isn't just about providing relief; it's actually providing some level of treatment and advancing their progression rather than just managing it as such.
Yeah, there's actually repair that can occur, and I think that's really encouraging. And there is, I suppose, some negativity considering the term wear and repair in arthritis, and, you know, avoiding that term. But I actually don't agree with that, because the condition does come from abnormal wear, but we can repair. I think that is what we're failing to actually encourage our patients. You know, your cartilage won't come back, but that's not what's causing your pain. It's the bone stress in the underlying cartilage that can repair. And I think the really lovely thing about, you know, I haven't published this paper yet from the PhD. I have presented it, where we showed the bone marrow bruising actually does improve really nicely with the orthotic and footwear interventions. And there are drug companies that are trying to find drugs that do that, yet we can do that with just shoes and orthotics. And it's, you know, there's a degree of not reversal, but improvement in the bone health. It's not just about symptoms, it's about improving bone health with our interventions, which I think is pretty amazing.
So Narelle, you've talked a fair bit about what the sort of improvement that can be seen with treatment, and you've talked about a range of treatments there. What to take the other position? What's the prognosis for PF osteoarthritis if it's left untreated?
If it's left untreated, it could go, well, one of probably three ways. It could get better, not saying better, the symptoms may reduce if the person manages to adopt some very good compensatory strategies, which have a price to pay. Those strategies mean usually not flexing the knees much during a lot of everyday tasks, which mean they get a progressive quadricep weakness and so on. And sometimes it can be that they end up with more lower back pain because they're not flexing their knees when they bend. You know, there's usually a price to pay, but their knee may not progress. So that can be one outcome. But often if the abnormal loads aren't changed on the knee, it ends up at a point where the joint is so dysfunctional it needs replacing. And that is it's a challenging thing to replace the patellofemoral joint alone. I have one patient out of all the knee arthritis patients that I see. And I do live in a retirement state. After all, we have a very old population here in Tassie. But I have one patient with a patellofemoral joint replacement. Everyone else pretty much will end up with a total knee replacement. Even if the tibiofemoral joint is not that bad, that is the end stage for the actual patellofemoral OA, unfortunately. But it is a successful outcome mostly if you do the total knee replacement. I had one really interesting example, though, recently of a patient who had a total knee replacement and on the opposite leg had a total ankle replacement. And his knee replacement knee started getting patellofemoral pain, but he's very already. So when they do replacements, they sometimes only shave the back of the patella and put a small plastic button in, or they may not actually do anything to the patella at all, but just replace the tibiofemoral side. And what had happened is because of his ankle replacement on the other side, he had been loading too heavily onto the knee replacement side. And once we got him in some orthotics and a heel raise because he had a leg length difference from all his joint surgeries, I hadn't quite leveled him up. He was quite comfortable thereafter, but a knee replacement doesn't guarantee that you'll be patellofemoral pain-free. It can be quite a bit of discomfort afterwards.
I'm sure there's a lot of patients who don't realise that, unfortunately, Narelle, and only realise it when, after they've been. I was going to say too late, but it's not actually too late. It's actually more a case of after having the surgery. Are there distinct stages of patellofemoral osteoarthritis? And I mean, you touched on surgery quite heavily there, but is surgery the only real option for end-of-stage patellofemoral osteoarthritis, Narelle?
Yeah, I mean, the definition of end stage, normally is where we don't have any joint space left at all, so meaning the cartilage is completely gone, and that there's significant osteophytes or bony growth around the margins of the joint. It is actually possible with what we would call radiographic end-stage arthritis to have not a lot of pain. We did see that with some of the people we were following in the PhD. If we can level out the joint load sufficiently, sometimes it can be an end-stage joint that is not particularly painful, which is obviously a great place to be. But yeah, there's not really, aside from the injectable therapies, there's not a lot else that can get done at this point in time.
Narelle, you've shared some fantastic information today, and you've given us a real insight into the condition. So you've touched on a range of things, including some of the treatments and some of the options available and some of the phases of it. So thank you so much for that today.
No worries. Thank you very much for having me. Once again, it's nice to try and get some of the simple bits of information out to all of us who see it on a daily basis.
Yeah, thanks, Narelle. And it's obvious that podiatrists are very well placed to be in a position to do a great deal of management and a lot of the patients that are afflicted by the condition. That pretty much wraps us up for this episode. For our listeners, we welcome your feedback and requests for podcast topics. You can email your feedback on any of the topics you might like to hear more of to info@podiatry.org.au. Don't forget to check out our website, podiatry.org.au, as a source for ongoing updates on a range of topics for podiatrists. And also, when you have a chance, look at our social media feeds at facebook.com/Australian Podiatry Association, one word, or Twitter at APODA_national. In the meantime, thanks to you, our listeners, for listening. Thanks to Narelle again for your great insight tonight, and we look forward to hearing you all next time. Bye for now.